Okay. It is 12:45 Pacific, 3:45 Eastern, so welcome everyone. My name is Nisha Modi, and I am the Associate Director of the Network of the National Library of Medicine, Pacific Southwest region at UCLA. Before we hear from Dr. Pernell, our keynote speaker, I have a few small items to cover. We have everyone muted to cut down on background noise. If you would like to make a comment or ask a question, please use the chat box and send it to everyone so the person monitoring the chat doesn't miss it. If there is time after Dr. Pernell's keynote address, she will answer questions. We're running on a tight schedule, so we'll end on time so everyone can attend the closing session. This session is being recorded, and it is also eligible for Certified Health Education Specialist credit and CE credit from the Medical Library Association. We will be sending out an evaluation at the end of each day. Completing the evaluation is the first step in claiming your CE. If you are sharing your conference experience on social media, please use the hashtag NNLMinfodemic21, which will also be pasted in the chat box. And now on to our keynote speaker. Today, Dr. Chris T. Pernell is sharing a presentation titled "The Tale of Two Americas: How Two Pandemics Collided and Cost Black and Brown Lives, and the Racial and Health Justice Mandate to Save the Future by Every Means Necessary." Dr. Chris T. Pernell is a dynamic physician leader and social change agent. In her public health practice, her focus is health justice, community-based advocacy, and population-wide health promotion and disease prevention. Recently, she joined University Hospital in Newark, New Jersey as the first strategic integration and health equity officer. She oversees a portfolio which includes population health, strategic planning, community affairs, and the human experience. Her office is responsible for health equity strategy development and integrating equity and inclusion within the system and across all operations. Prior to joining University Hospital, she led the 1199 SEIU League Labor Management Initiative's Workplace and Community Health Program, working with leaders and frontline workers of 1199 SEIU and partners across New York City healthcare institutions. Her efforts centered on workplace health strategies, worker empowerment, health equity, and health system transformation. Dr. Chris is a charismatic and leading voice in preventive medicine and public health. NJBiz named her a public health hero in 2020. Known for her spearheading work in the greater Newark, New Jersey area, she was tapped to serve on the Essex County Civilian Task Force as a medical expert. Prison reform and care for justice-involved populations, along with issues such as evidence-based wellness programs, civic health, and high-quality education have been areas of impassioned focus. Dr. Pernell is a frequent contributor across television, radio, and print media, leveraging her lived experiences and expertise as a public health physician and health equity champion. Dr. Chris graduated cum laude from Princeton University before attending Duke University School of Medicine. She received her Master of Public Health from the Columbia Mailman School of Public Health and completed the Johns Hopkins Bloomberg School of Public Health General Preventive Medicine residency. Dr. Pernell is a fellow of the American College of Preventive Medicine and holds an appointment as a clinical assistant professor at the Rutgers, New Jersey Medical School. Thank you so much, Dr. Pernell, and you could share your slides. Excited for your presentation.
Good afternoon, everyone. I'm very, very excited to have this opportunity to have this conversation with you today and to have this conversation at this juncture in our nation's history and this juncture in global events. And so hopefully the story that I'm able to share alongside of the data and alongside the lessons, the best practices, the goals, and the hopes will be illuminating and can spark conversation that starts with action planning today, but that we all carry through our mission and mandate in our respective roles in our respective lives. So I'm going to share my screen at this point. The Tale of Two Americas. how two pandemics collided and cost Black and Brown lives, and the racial and health justice mandate to save the future. That was a very deliberate title there. And what we will do as we journey through today's session is that we will have an understanding of the health inequities, resulting health disparities that were exposed through the coronavirus or the COVID 2019 pandemic really has crystallized a truth that has already existed in our soil for quite some time. And then we will use that lens, that provocation of the truth that has existed in our soil to think through what are the imperatives around change, what are the imperatives around transformation, and what are the imperatives around progress. As was mentioned, I am the Chief Strategic Integration and Health Equity Officer at Newark University Hospital here in Newark, New Jersey. And this is my home. This is my backyard. And so these stories are not just personal stories that impact my family, but these are stories that impact my community. So I always start here. Before I give any numbers, I think it's important for all of us to focus on souls, to focus on lives, to focus on faces. And this representation was done by ABC News, and it struck me the first time that I saw it, and just the diaspora that is the United States, and the diversity of people who have lost their lives, and all of us have been impacted by this unprecedented public health crisis. So I want to ground us and start there. I'm going to take my cursor, and you see me circling the face of this woman here with that big bright smile. This is Kim King-Smith. Kim King-Smith was the first staff person here at University Hospital that lost their life to coronavirus. Kim worked the night shift. Kim was an EKG technician. She had been a part of the University Hospital family for over decades, and we still grieve her loss, and we continue to say her name because it is so important to remember that these data points are not just blips on a screen, but they're vacancies in our personal, organizational, community, city, state, and nation fabric. So some key facts. The first confirmed case in the United States was reported, and this is laboratory confirmed, case of coronavirus was reported on January 20th, 2020. I want that date to be etched in your mind, and then to fast forward to where we are today, April 9th, 2021, and to look back and to think about how so much has changed, not only in our nation, but in the world, and what must we do not to regain our normality, but what must we do to redefine our social, cultural, financial, economic, political fabric to ensure equity and justice are realized. The CDC reports that approximately 556,000 lives have been lost to date. And I wanted to have the most recent information, and this was as of last night, and about 31 million cases of coronavirus infection. The US 7-day moving average of daily new cases was roughly 64,000. And that's important because we're at a baseline where we have plateaued, and that causes a sense of greater concern, vigilance, and caution in this pace to outrun the variants through aggressive vaccination goals. So those are some data points that I want us to have at the backdrop for today's discussion. And so we start here. This is my beloved father. This is Timothy L. Pernell Sr. I lost my father almost a year ago exactly. I lost my father on April 13th, 2020 to coronavirus. I want you to imagine me, a physician executive in a hospital, and 4 miles away, a mere 4 miles away, my father is fighting for his life and ultimately loses that battle. My father didn't go into the hospital with a coronavirus infection. My father was exposed very in the early days of this pandemic when it was New Jersey and New York were the epicenter. And it felt like we were in the fog of war. I can testify of that because as a part of the leadership team here at University Hospital, responding to fast changing information. The science was being discovered on a daily basis, learning how do we treat this? There were no approved treatment regimens. How do we prevent this? What are the baseline public health measures and guidance that we give to community, we give to our patients to keep one another safe? How do we keep our staff safe? So while I'm dealing with all of that and the fluctuation of the ebb and flow of our reality during those days that sometimes are a blur, I lost my dad. My father was 78, Black male, had multiple chronic health conditions. My father had survived and was living with chronic HIV/AIDS infection. So my father had benefited from the strengths and the advances of clinical medicine. My father also had emphysema and had an end-stage lymphoma, but it was coronavirus that he got exposed to and ultimately ended his life. And I think those facts are important for you because they're going to be some of the disparities that are evidenced in the disproportionate impact that coronavirus has had on Black and Brown lives. I started with showing you that diversity of faces across the United States because we all have been touched by this virus. We all have experienced loss, but some of us, we have experienced disproportionate impact. And I think it's very important that we tell that story. And in addition to losing my beloved father, my sister is a COVID-19 long hauler. My sister got exposed the week of my father's virtual funeral service. My sister worked, or I should say got diagnosed the week of my father's virtual funeral service. My sister worked at a large retail chain. That's an important fact. My sister didn't have adequate access to PPE. Again, in the early days of when New Jersey was an epicenter, we used to have conversations and I said, Kim, do you have plexiglass barriers? Because those are some of the things that we were ultimately going to do here at the hospital. I said, do you have access to enough face masks? And those things were limited for her or non-existent. So I definitely had concern. My sister had survived breast cancer. She had endured a mastectomy. She had endured chemotherapy and radiation. It was just back at work, getting exposed, being sick. My sister was never hospitalized. I think partly because of the fear of hospitalization still at that time. She definitely struggled with symptoms of home, struggled with her breathing and me trying to provide care as best I could virtually and having her reach out to her primary care physician. So I think it's important that we understand these real world scenarios. Black women are 2.5 times more likely to know someone who has lost their life to coronavirus. And I am one of those Black women. Not only have I lost my father, not only is my sister a COVID-19 long hauler, it took her about 10 months to regain some semblance of her baseline and return to work, although she has residual symptoms still. I lost two cousins just before the new year. One of those cousins was a postal worker in Newark, New Jersey. So again, a critical infrastructure or essential worker who kept working during the pandemic, got sick, went to his doctor. His doctor was treating him for an upper respiratory infection, did not immediately get tested for coronavirus. That's another fact in detail that I want you to remember and reflect on. The weekend before my cousin had a catastrophic stroke and was found down at home and then ultimately lost his life a few days later. He was scouring the city to find a testing site to confirm whether or not he had coronavirus because he wasn't getting better from the antibiotics for a supposed upper respiratory infection. And my other cousin who lost his life again was an older Black gentleman with multiple chronic health conditions who had a very long battle with coronavirus in the hospital and ultimately succumbed. So a tale of two Americas. What we politely call a health disparity is killing people of color daily. It is causing people of color to live sicker and die quicker because of the color of their skin. This is a quote that appeared in a Brookings Institute article around June of 2020. But this is by the esteemed dean, professor and social scientist, Dana Bowen Matthew. She is the author of Just Medicine, A Cure for Racial Inequality in American Healthcare. And she talks about this sense of mandate. I remember the first time I'd heard her speak, a mandate for healthcare institutions to become hubs of racial healing. And that is not ways that healthcare settings traditionally think of themselves as, but her challenge was it is necessary for healthcare anchors to fill that role. And in order for us to fill that role, we have to think about health disparities, not in this academic or this dispassionate place. We need to think about the inequities driving those disparities and the power systems such as white supremacy and structural or institutional racism creating those barriers. So what is health equity? Health equity is defined as everyone having the opportunity to achieve their highest level of health. And I use the definition that the American Public Health Association, this being the National Public Health Week, has put forth, because I think it adequately and appropriately captures the essence of what is meant by health equity. Everyone. What is meant by health equity? Opportunity. What is meant by health equity? Highest level of health. Everyone has the opportunity to achieve their highest level of health. But inequities are created when you have these barriers. And it's important to understand that these barriers are unjust and these barriers are avoidable. But these barriers prevent communities from accessing the conditions, the place-based settings, the resources, those social determinants of health. It prevents people from accessing the conditions and reaching their full potential. And finally, inequities are different from health disparities. So health inequities are not health disparities. People use those terms interchangeably, but they're not. The health disparity is simply the difference in the health status between people, whether it's based on a social or demographic factor, such as race, such as gender, such as income, or such as a geographic region. But the inequity is the barrier itself, and the barrier is unjust and avoidable. Another quote for you: of all the forms of inequality, injustice in health is the most shocking and the most inhuman because it often results in physical death. I started out telling you that over 556,000 Americans have lost their lives in this pandemic to date. And I told you the story of my father being one of those, my two cousins, Thomas Franklin Boswell Jr. and William Boswell Jr. being two others. And my sister didn't lose her life, but the morbidity associated with it, my sister being a long hauler. This quote, this narrative, the forces that caused Reverend Dr. Martin Luther King Jr. to say what he said still exists with us today. And the COVID-19 pandemic has elucidated that for those who maybe were still on the fence, but crystallized for many of us who knew of these entrenched disparities resulting from these almost immovable inequities that had seemed at times. But they're not immovable. They need and require the appropriate level of action to dislodge them. So what is racism? Very important to name this. Dr. Kimara Jones has been prolific in this space, a past president of the APHA, an epidemiologist and scholar, defines racism as a system of structuring opportunity. Racism as a system assigns value based on a social interpretation of how one looks, your skin color, and we call that social interpretation race. Racism unfairly disadvantages some individuals and communities. Racism unfairly advantages other individuals and communities. Note, both of it is unfair. And racism saps the strength of the whole society through the waste of human resources. So racism costs. It doesn't only cost Black and brown persons who are disproportionately impacted by it, but racism costs us all. These are the 4 dimensions of racism put forward by the Slow Factory Foundation that I've used in so many of my talks, or helping people to understand how that system operates. That system operates at a structural level. Okay, so think about that across multiple sectors. Think about that across multiple organizations, multiple institutions. That system operates at an institutional level. Think about your workspace or your particular organization, your particular school, your particular job sector, interpersonal, between persons. racist acts or even microaggressions, and think about internalize, how we have internalized the system of racism, a system of structuring opportunity where we unfairly disadvantage some and unfairly advantage others. So when we talk about COVID-19, through that growing understanding that I just presented, what is health equity? What is an inequity? How does it differ from a disparity? And what is racism? And now we can talk about the collision of those two pandemics. The fast pandemic being coronavirus. I started with that date, January 20, 2020, just to show you how fast it has been. This virus, unknown to us before it was discovered, and probably was circulating in community as far back as maybe November or December. Epidemiologists have posited, but first confirmed diagnosis in January. This virus has left in its wake untold devastation and destruction. And it has happened at a very rapid pace, not just in the United States, but across the globe. That virus, that pandemic has collided with the pandemic of systemic racism. And that pandemic has been with us. It is almost endemic to the soil of the nation because it very much existed in the founding of this nation. It's very much permeated every aspect of American life, practice, or business, founded on the fallacy of white supremacy. And so when the CDC talks about the disproportionate impact of coronavirus on Blacks, Latinos, on American Indians or Alaskan Natives, on Asians, I want you to think about that collision course and how that collision course has caused earthquakes of devastation in Black and Brown communities. The CDC calls it race and ethnicity as risk markers. You can read the quote there. I go further and I say it's not race and ethnicity that are the risk markers, and others in the field have said the same. It's racism that is a pre-existing condition that has made the disproportionate impact that much more devastating for these groups. So in hospitalizations and death, you can see the numbers there on the screen for you, anywhere between 1 to almost 4 times higher in certain groups. Let's look at Asian for a moment. There is a lot of diversity within who is Asian. And I pull out a stat specific to New Jersey, though here it would see that Asians have not fared as worse as others in the BIPOC community. I can tell you in New Jersey, coronavirus is a leading cause of death for Asians, Latinos, and for Blacks, okay? So in addition to hospitalization rates, death is anywhere between 1 to 2.4, and certain research organizations say that risk has been as high as 2.7. And I'm gonna give you some numbers that further crystallizes that risk, okay? This is a Color of Coronavirus project done by the APM Research Lab. And this is another one of those research organizations that has looked at the disproportionate impact of COVID-19 deaths by race and ethnicity. And here you see their numbers, and this data was updated as of March 2nd. They send out updates typically on average once a month. And there you see the differences in the proportionality of who has experienced the death, and very similar to what the CDC is reporting. And this is not with the most comprehensive data set. Another way for us to conceive of the disparity. I remember when this news broke, when this came out and said either directly due to lives lost to coronavirus or indirectly due to people foregoing necessary care or delaying necessary care, that Americans had lost a year off of their life expectancy. That's dramatic. And I hope everyone understands that. We haven't seen those type of numbers or that reality. We would have to go back to the Depression, and we haven't seen that in recent history. And this is how catastrophic coronavirus has been for the nation as a whole. But if we dig deeper, because remember, it is the collision of 2 pandemics, it is the tale of 2 Americas. If you dig deeper, and these are the groups that the most comprehensive data was available for, hence why the National Center for Health Statistics reports on Blacks, the Latinx community, and not Hispanic whites. And typically they don't release this preliminary data at the halfway point. but Blacks lost on average 2.7 years, almost 3 years of their life expectancy. Hispanics lost 2 years of their life expectancy, and whites 1. If we break that down even further, right, and think about the intersectionality of those power dimensions, those axes of power that are asymmetric and imbalanced and have led to these inequities, Black males have experienced the worst in the loss of life expectancy. Black males have lost 3 years. Black women approximately about 2.3, and so on. And there's additional research that is coming out that talks about how Black women have fared disproportionately in comparison with white men, with Asian men, and with Latinos. Another stat here. So the Brookings Institute back in June did a very revealing piece on the race gaps in COVID-19 deaths. And just to emphasize to people, look, these are wider than and bigger than they appear. So I showed you the very preliminary meaning earlier in the presentation around those differences by race and ethnicity, upwards to 2.4, even 2.6 or 2.7. But if you look by age category, in every age category, Black people are dying from COVID at roughly the same rate as white people more than a decade older. That's a quote from this article. And this is why you heard a lot of people talk about our vaccine eligibility criteria was not built or designed to maximize equity, because we were using false cutoffs by age. When Blacks Blacks and Latinos were experiencing disproportionate outcomes at younger ages than were white people. And that was something that was revealed through this analysis. And this is startling here. Among those aged 45 to 54, for example, Black and Hispanic or Latino death rates are at least 6 times higher than for whites. And I want us all to pause, and I want that to rest, and to think about those who have lost their lives at that alarming rate, hence the collision course of 2 pandemics. Now let's move and transition to vaccinations. Losing my dad, my father was a heroic man. And I say he was a heroic man because my father endured and overcame so much. My dad endured the Jim Crow South and overcame it. My father went north like a lot of Blacks following that migratory pattern, leaving a lack of economic opportunity, fleeing the horrors, lynching, and what's so forth of the South, and went north, settled in New York, where he had family, ultimately married my mom, and we were raised in New Jersey. But what I want you to know about my father is that my father gained access to a professional career by cutting grass. My father was at Bell Labs, and he started there cutting grass, and ultimately, through opportunity, through engagement encounters, my father was self-taught. He never went to college, but he became a member of the technical staff and was a part of groundbreaking research teams that did call waiting, caller ID, 3-way call, and things of that nature. And so even with being of a certain socioeconomic status, it wasn't protective of the other conditions that my father experienced that increased his likelihood to develop certain diseases. And so we couldn't just say it's because Black and Brown people have more chronic health conditions that they're dying. It's not just because they have more chronic health conditions, because those chronic health conditions are oftentimes rooted in place-based factors. And that's why it is important to go further upstream and to talk about the system of racism. So with that backdrop, losing my father, being a public health physician, my sister being a long hauler, seeing in our hospital nearly every bed filled with a Black and Brown person. We serve a Black and Brown majority city here in New York and beyond, but nearly every bed in our hospital filled with a person struggling with coronavirus during the height of the pandemic back in March and April. Alarming situations and stories, losing ultimately 12 staff persons, and they were predominantly persons of color that we lost. I needed a way to be a part of the solution. So I signed up to be a part of the COVID-19 vaccine trial, the Moderna trial that was offered at Rutgers, New Jersey Medical School. And it was an important journey for me because it was a way to demonstrate accountability. It was a way to understand how information is messaged around the opportunity to participate in clinical research. We had initially some anger, some pushback in community about why are you participating in this? Blacks have experienced enough harm. Why are you subjecting us to this that could potentially harm us? But helping community, cultivating, hearing those concerns, not ignoring or denying histories, not ignoring or denying truths, not denying or ignoring lived experiences, but helping community to understand in plain spoken, socially and culturally fluent terms what the opportunity to participate meant. It's definitely voluntary. And informed consent, which is a sacred process, was upheld. And sharing what the risks were known to be at that point, no serious medical events had occurred, and what the perceived benefits would be. And ultimately, those trials, whether Moderna, whether Pfizer, whether J&J, the 3 that have been approved through emergency use authorization, got us to this moment right now, where we've had at this point, this was as of the 8th, at 6 a.m., so we're beyond this, more than 175 million Americans have received a vaccine dose. At least 112 million at the time of this data poll had at least 1 dose, and 66 million were fully vaccinated. That is a success. That is a measure of success and should be celebrated. But it is not aggressive enough to where we need to go when you start to break down who are those who've been vaccinated and who are those who've not been vaccinated. In the city where I work, the city of my family, my community, only 8% of workers have been vaccinated. And so we have a FEMA mega site here. We offer vaccinations here at our hospital. You have federally qualified health centers that are starting to do more mobile vaccination units. You have our county that has a very aggressive vaccination program, but yet we're not achieving the equity. And so we have to double back and say, what is the missing piece? What do we need to do more of? We need to penetrate more deeply into community and to have those trusted messengers and to have that message spoken in plain spoken terms and to come across in an authentic way so that people can understand the risks versus benefits, that they can understand that Blacks and Latinos bear a disproportionate risk. It's not the same risk as everyone else. In that in bearing that disproportionate risk, it's not only associated just with exposure, because that exposure risk is oftentimes tied to the job that you work. We have research that shows whether it's death by racism, written by Sherelle Barber, that looks at census tract data and say Blacks and Latinos occupy certain industries more. 43% of the service and production industry is occupied by Blacks and Latinos, as opposed to roughly about 25% by whites. And the exposure risk associated with certain jobs, is it a high contact job, a job where you are in crowded or even cramped quarters, distribution centers, meat packing centers? It is a job where you are required to show up to work. Remote work isn't an option. A grocery store, a pharmacy, a hospital, oftentimes a postal worker. Is it a job where you can't afford not to work, meaning you're not receiving a living wage, you're an economically vulnerable household? Those are the factors that are dictating outcomes as much as well as whether or not a person has a chronic health condition. And even, do you live in a house that's probably multi-generational, a house but it's crowded and cramped so that if a person gets exposed, they can't adequately quarantine, or if the person gets infected, they can't adequately isolate. If you break down those numbers by race and ethnicity, you see fully vaccinated, and this was as of that data poll yesterday at 6 a.m. And remember, you don't have a comprehensive data set of the 66 million plus that were fully vaccinated. You have race and ethnicity data for about 38 million, 8.7 were Hispanic or Latino, but that paled in comparison to their representative share of the population. The gray shading is their representative share of the broader population. Look at Blacks, around 7.9, that pales into comparison to their representative share of the population. And you can see where we are with first doses as well. And you can see that whites are overrepresented in those who have been vaccinated, overrepresented in comparison to their population share. Very fascinating here. So if we look at willingness, enthusiasm, opinions or concerns around wanting to be vaccinated or already having been vaccinated, we're starting to see very interesting trends emerge. A lot was said about hesitancy in Black and Brown communities. There were polls that adequately showed that hesitancy probably wasn't the most appropriate term to use, as it was that certain subsets of groups, Blacks in particular, we'll talk about them specifically, occupied a wait and see category. And it wasn't a definitely no. It wasn't a only if you make me, meaning only if it's mandated. The wait and see is I need more information. And I need information that directly addresses my lived experiences, not just historical injustices, but what I see every day. My present contemporary experiences with racism, experiences with injustice, experience with health inequities, and even in the healthcare setting, and even in clinical research practices. I need information that addresses those concerns and that addresses, what are the costs associated with vaccination. I'm going to get into that a little bit more, but this slide is important because it shows you we actually have more concerning pockets of definitely no's among Republican men, among white men without college degrees, among white evangelical Christians than we have among Black and Browns, but that's where a lot of the narrative has rested. So it's going to be very important to understand the different motivating factors that make a person more likely to get vaccinated, and how those motivating factors very much rest in who they are, their identity, and how that identity is shaped by their social sphere and by the culture and even by their political affiliations. Kaiser Family Foundation, in addition to the NPR and Marist and PBS NewsHour poll that I just showed you in the previous slide, has looked at this topic and has focused a lot on where are the opportunities to move, meaning why are certain groups falling in certain categories. And I think it's just very important, very quickly to trend from December 2020 through March 21st. This is for Black adults who have been represented in this particular Kaiser Family Foundation survey. If you look at the blue line, the more royal blue line, the wait and see category, you see that has fallen. And what's happening usually is a conversion to the already gotten or as soon as possible, because this person's information needs are being set. This person's trust needs are being set. This person's access needs are being set and met. But you see the only if required and the definitely nots are not as high as in other groups, and they really haven't changed. If we compare that with the Latino community, again, you see the dark blue line going up, there's a trajectory higher, and you see the wait and see category going down when those needs are met across that time. This is encouraging. When those needs are met, that action is delivered. When you take people along a decision journey, and that's what we're able to do with narrative, with storytelling, with information. We're taking people along a decision journey. And when you do that, a person goes from that awareness stage, to that motivation stage, to that intention phase, to that completion of an action, and to that follow through, especially a follow through when you have 2-dose vaccines. And if you compare that to whites, likewise, you've seen this increase in white Americans who have already gotten or are willing to get vaccinated as soon as possible. I just want to go back and see the slope. I want you to notice the slope of the already gotten or as soon as possible, and see how that slope differs across race and ethnicity. The wait and see category likewise has dropped amongst whites. And you see that line of definitely not, or only if required. Definitely not here is sub the 20s, right? So about 15 or so. And in Latinos, that definitely not is about the 8 mark. And in Blacks, that definitely not is about the 10. Okay, so racial and the health justice framework. If we think about issues that drive these inequities, I wanted to group them in 4 categories. These aren't the only 4 categories, but I think these are 4 very key and priority categories: access, trustworthiness, social and cultural fluency, and health literacy and language. Again, access, trustworthiness, social and cultural fluency, health literacy, and language. Let's talk about access. Dr. Cameron Jones, who I quoted earlier, whose definition of racism I just think is the best definition, that is the most accessible for us to understand how it operates as a system, talks about the access is really divided amongst access to care. So you see differential access to care across racial and ethnic groups. You see differential quality in the care received across racial and ethnic groups. And you see differential or unequal, unjust access to life opportunities across racial and ethnic groups. And all of that impacts access. Okay, and some of the things that impact access to care we'll talk about in the next bullet, but let's just talk really briefly about the quality of care, implicit bias, how that impacts interactions, whether symptoms are believed, access to early testing, whether or not certain persons needed to be tested earlier on in the pandemic, how different treatment regimens that are used and chosen, not just specific to coronavirus, but more globally, and a lack of a culturally responsive care system, unjust access to life opportunities. We're talking about those social determinants of health, where you work, where you live, where you play, where you are born, where you age, where you pray. Those things impact your exposures, and those exposures carry differential risk. And unfortunately, devastatingly, unjustly, and unfairly, the accumulation of risk is greater in certain racial and ethnic groups. And so specifically around vaccine equity, when we're talking about how do we get information to people and how does that information then convert into an action or behavior, we have to think about convenience factors. And those things are related to time, how much time is required, where are those vaccine opportunities located, how are people able to get to those vaccine appointments, and cost. There is a perceived cost, meaning it may not cost me dollars specifically at the point of transaction, but do I have to take time off from work? Are the hours convenient that I could get vaccinated and not impact my finances or my economics? Those are some of the important things we got to think about. Trustworthiness. We talk so often about trust, and the onus is on institutions, organizations, systems, powers demonstrating trustworthiness. The demonstration of trustworthiness allows or facilitates the growth and development of trust. So the use of credible messengers, community health workers are an example, influencers in specific communities, whether those are faith-based leaders, whether those are barbershops or hairdressers, whether those are social cultural organizations, whether those are your primary care doctor, or those are primary care doctors, physicians, healthcare providers more broadly, who are race concordant, look like the group that you want to be able to share information with and then convert to an action. Trusted social spheres. That's how trustworthiness is demonstrated, operating along trusted social spheres, and also understanding the role of historical and contemporary injustices. We don't just speak the names of, the Fannie Lou Hamers, who can be representative of the Black women who were subjected to forced sterilization under some other medical guise that happened to Black and Latino women. We speak the name of Henrietta Lacks. We speak the name of those men who endured the untreated syphilis study in Alabama. And so it's not just those historical things. The women, the enslaved Black women who were subjected to gynecological procedures without their consent and anesthesia. But we talk about contemporary injustices, and atoning, reconciling, acknowledging demonstrates trustworthiness. We need to do that in the information that we share as well. And that has to be done with a fluency. I don't say competency, I say fluency. So amplifying the narratives, what we know is that when a person in a family or in your circle completes an action or completes a behavior, you're more likely to then validate and say, okay, this is something that I will consider or do. And thinking about multimodal health education campaigns, not just the traditional. We here at the hospital had to think about care around the clock. How do we get information out to the community, especially when community still wasn't coming back into the hospital around the time of late spring, early summer for care? So we use social media. cognizant of social divides. There were phone calls made to certain groups, leveraging certain organizations who either had phone prayer lines or phone meetings, multimodal, video, audio, text, print, multiple ways of communicating. And not only multimodal health education campaigns, but leveraging trust-infused social networks to get that information out. It's not just informing the information, like using a trusted influencer or a credible messenger to inform the information, but using a trust-infused network to get the information out. That's a very important distinction. And finally, health literacy and language. We have to speak in ways that people can understand, especially where there's fear, and we validate it, especially when there's concern, and we validate it. And we have to speak in preferred languages. You know, I had a physician reach out to me and said, look, Dr. Chris, can you help? I know you're doing a lot around advocacy around the vaccine, but we have elderly Spanish-speaking persons in this ward of the city, and I feel like they're getting left out in this mix. They're not online. They're not necessarily here at the doctor's office. How can we get the message to where they are? A lot of what we're learning about equity, when you lead with equity, you can't wait for people to build. You can't build it and they will come. You must go to where they are. That demonstrates your trustworthiness. I show up where you are. I show up in your place. I show up in your condition. And I say, these are the services, or this is the information, or this is the opportunity. And then I build a bridge, a way for you to have access to that. That's equity, what you need. It must be predicated on the needs of the group, whether it's a historically excluded or marginalized community or not. It has to be predicated on the needs of the group. And finally, just 3 last slides to talk about where Kaiser Family Foundation, fascinating data. They do this monitor report and they usually release it on a monthly basis. What are the trends that they're seeing? Black and Hispanic adults are more likely than white adults to express concerns about not being able to get the vaccine from a trusted place, or having difficulty traveling to a vaccination site. And so you can see it's just some of the different takeaways. Might experience serious side effects, how that ranges, might be required to get the vaccine even if you don't want to, how that ranges, might miss work. You see how that's higher in Black and Latinos than it is in white. So there's a cost association. You might get COVID from the vaccine. There is still some way we are not penetrating the understanding in those groups that the vaccine itself does not cause COVID. And thinking about how disinformation and misinformation is being targeted specifically at certain vulnerable and marginalized populations. What are we doing to counteract that or to get ahead of that? You won't be able to get the vaccine from a place you trust. That is ranks higher amongst Blacks than Hispanics or whites, and the difficulties associated with transportation. Just fascinating. Also, the same monitor report looked at, who said that messaging in and of itself moved their action. So let's just look through some of the different messages or things associated. That vaccines are nearly 100% effective at preventing hospitalization. That matters more to certain groups than others. And when I say groups, and I talk about race or ethnicity, I'm talking about where people fall in the decision journey. That definitely matters to someone in the wait and see category, which we know has been dominated by Blacks dominated by Blacks and Browns. It matters less to someone who's a definitely no. Okay, another example, more than 100,000 people from diverse backgrounds and ethnicities participated in vaccine trials. That matters more, again, to that wait and see category. That wait and see category, we see more Blacks and Latinos falling into that category than others. That matters. Messages around that, hearing that the vast majority of doctors who've been offered the vaccine have taken it, that matters. Whether or not there are long-term side effects, that is about similar between wait and see and only if required. And it's just fascinating here. In this last one, even though most people who die are older or have other health conditions, some young and healthy people have also been hospitalized and died. That again matters more in that wait and see category. And that wait and see category is more likely to have Black and brown persons in it. That's why those categories are important. And finally, not finally, one more slide to go, but near finally, half of those who want to wait and see said they would be more likely to get the vaccine if it was offered at a routine medical appointment. That's important because it talks about convenience. It talks about using the agency of a provider. It talks about trustworthiness of a provider. And it talks about a social fluency, understanding the role of a provider in a particular community's life. And if you look across the different categories, again, the wait and see versus the only if required versus the definitely not, you see where you see any variability, if any at all. The greatest place you saw variability is if it were offered at a doctor's office when you go in for a routine medical visit. And finally, you hear these terms, and this is the quest, the imperative to save the future by every means necessary. Inequality is unequal access to opportunities. Equality, is that the answer? Meaning evenly distribute tools and assistance? No, because you see the person when the tree is leaning away from them, the opportunity is further from them, that equal amounts of intervention or equal amounts of tool doesn't solve their issue. Is it merely just equity? And it's not, equity isn't a merely, and so I don't want to diminish or devalue the importance of equity. But is it equity, meaning custom tools that identify and address the inequality, meaning based on what your particular needs are? So yeah, I give you a higher ladder. Okay, you can reach the apple, but the tree is still bent in the other direction. Justice is making the tree upright. And hence why we must get to a racial and health justice outcome if we are to undo the systemic pandemic that's been with us, the slow pandemic. And undoing that pandemic allows, when we're facing unprecedented public health crises, for them not to be disproportionately impacting Black and brown groups or certain racial ethnic categories. Thank you for the opportunity to share.
Thank you so much, Dr. Pernell. I was just at every word listening to what you were saying. Always very impressed by your compelling storytelling. So thank you so much. Yeah, and thank you so much. Sarah was putting all the links to all the great stories you shared with us in the chat. So I'm so glad. I do see one question that asks, why are vaccines widely available in medical offices and hospitals?
Not, right? So they wanted to reform that to, I'm assuming that asterisk.
Oh, not, why are, yeah, I was just like, wait.
Yeah, and so it's a very good question, right? So it started out a logistical issue at first. Think about the order of when vaccines became approved under emergency use authorization. So Pfizer has very specific ultra cold storage requirements, and those very specific ultra cold storage requirements usually could not be handled by private doctors' offices. Hospitals, on the other hand, not all hospitals, but hospitals would be more likely to be outfitted or have the access or opportunity to be outfitted with those ultra cold storage facilities so that hospitals could make a vaccine available more readily than a private doctor's office could. You saw when Moderna got approved, Moderna, likewise, both of them are messenger RNA vaccines, had cold storage requirements, but not as cold as the Pfizer cold chain requirements. And Moderna had a slightly longer refrigerator shelf life than did the Pfizer because it didn't have the same cold, ultra cold requirements. Again, making it one step closer to being likely that a doctor's office could be able to offer it. And then you have J&J. J&J is not an mRNA vaccine. J&J is a vector-based vaccine. So it uses a weakened, changed, attenuated cold virus to act as a carrier, puts a gene in that's been spliced with a spike protein, and then that gets carried into the person's cell. It's not a messenger RNA, so it's not as fragile. Messenger RNA is fragile. You can transport it more easily, and you have a longer refrigerator shelf life. So increasingly, J&J would present for an opportunity for more doctors' offices to have access to the vaccine. So there's been this gradual progression to make that opportunity realized. But those were the challenges that initially those of us in the field were faced with.
Thank you so much. If anyone else has any questions, you're welcome to drop them. One actually question I had was, One thing that our opening keynote, Dr. Vin Gupta mentioned was, that it's important to lean into stories. And I feel you demonstrated that through your talk. And you also talked about trust. And I was wondering, in terms of building trust through storytelling, can you talk a little bit about that? And
Sure, definitely. And so I think it's very important, the messenger, what the messenger says, how the messenger says it, and the networks that the message goes out through. Okay, so the messenger, who the messenger is, what the messenger says, how the messenger says it, and how the message is transported through networks. Those four features or characteristics are ways that institutions, power structures demonstrate trustworthiness, so that communities where trust has been broken can begin to validate at each of those points and say, I can trust. Okay, so if the messenger is someone, we use race concordant, it looks like you or has some similar lived experience with you, that matters. That's why I let people know, even in a community of other Black people or in a room of other Black women, I've experienced what the majority of you have experienced in this pandemic. I lost my father, I lost 2 cousins, and my sister is a long hauler, right? So to show who I am is like who you are, okay? And then what I say, it's very important what I say. I have to touch into those lived experiences. So then I usually tell stories about the injustices or the biases I've faced in a healthcare environment, because I have a chronic health condition. And at times I've had doctors who have not validated my symptoms, who have told me things were in my head and has delayed diagnosis. I've been in situations where I've had family members where I had to fiercely advocate on their behalf for them to get the care that they need. So it's, again, me acknowledging and validating the experiences you also have are important. And it's how I say it, not just the what, but how. Do I speak in plain spoken terms? Do I speak with the person across the table and not above the person across the table or not beneath the person across the table, recognizing and valuing their humanity and their expertise, because they are an expert in their lived experience. They are an expert in their history. They're an expert in their family. They're an expert in why they have fear. They have an expert in why they have concerns. And then do I have awareness of the networks that are trustworthy? And those networks are not always traditional. The barbershop network is trustworthy, right? And so knowing that the faith-based setting network is trustworthy and the mosque is trustworthy. So knowing that and the different communities and groups, I think, are all the important things that we have to do.
I love those 5 components. I hope someone wrote it down, because I totally want to think about that and review it. So yeah, thank you for that. We have a few minutes left. Someone asked, what types of information resources can medical school libraries collect and promote to reduce health disparities?
Excellent question. Let's go upstream a little bit further. Let's think about first what medical school libraries can collect to promote and understand health inequities. That's why I want everyone to understand the difference of that. The health disparity is, think about it as downstream. That's just the differences in the outcomes. But it's like this. Dr. Jones, one of the first times I met her, Dr. Cameron Jones, said, you can't practice healthcare in a city that you know nothing about. You have to know the city's history, that particular city's history. You have to understand what are the lived experiences. So health systems, health institutions, medical school libraries, we need to collect the histories of the communities, the histories of the peoples that we serve. Because it is important to know you before I treat you. That matters. And that's a part of the social and cultural fluency. And then health systems need to, as Dana Thomas challenged us, to be hubs of racial healing. The only way a health system can be a hub of racial healing is for a health system to understand and to acknowledge racism as a system of structuring opportunity, where one group is disadvantaged unfairly and another group is advantaged unfairly. Health systems have to name the institutional racism and the structural racism. Health systems have to have dialogue and narrative around white supremacy. White supremacy is not just hoods. It's not just lynching. It's not just cross burnings. White supremacy is a belief system, a power structure. So health systems have to understand how that has shaped informed the practice of care. And finally, medical schools can have a collection of best practices, things that have been done to begin to chip away, to disrupt, and to dismantle those systems. Just like the system of racism is the one I'm focusing on, are the barriers that are in health and inequities, and say, okay, what are the best practices that can inform our practice here? Examples of collaboratives or coalitions across multi-stakeholder groups. We're a part of one here in Newark. It's called the Newark Anchor Collaborative, and understanding how anchor institution, whether it's an airlines company, whether it's an academic institution, whether it's a hospital, whether it's someone in private sector, how we're all different anchors and how we can come together. Medical schools need to show forth those best practices that are happening in that place-based setting approach.
Thank you. I really appreciate the upstream, downstream. I totally thought disparities and inequities as synonymous, but I really appreciate that framing. And, we are right at time. Thank you so much. This talk was wonderful to close out the symposium, and I'm so grateful for your time and your presence.
Thank you very much. Have a good day, everyone.
You too.
Hi, Mom. Sorry.
Oh, it's fine. That was great. Ooh, wow, that shoes were so good.
We're at closing remarks, correct?
I think so. Is this in the same room?
Yes.
Okay.
I'll just stay here.
Yeah.
We're in the same room. Apologies for my daughter. But I think that speaks to the lives that we all live in our real life. So thank you all. I'm Martha Meacham. I'm the head of the network of the National Library of Medicine, and I'm here to offer thanks and close out this wonderful event. So I'd like to thank all of our guest speakers, panelists, and paper presenters for today's presentations. You have provided fantastic information of the key issues that impact medically underserved populations, from accessing COVID-19 and vaccine health information. You've also shared case studies and research to help attendees with their outreach and education program. I'd like to especially thank our keynote speakers, Jess Colas and Dr. Chris Pernell, for today's keynotes. On going off script, they were absolutely fabulous, and I'm so proud and impressed with the wonderful work. I would also like to thank the planning committee that organized this fantastic symposium. The planning committee had representation from each of the regional medical libraries and NNLM offices. Members of that committee are John Bramble, Rebecca Brown, Kathy Burrows, Kira Comfort, Kelsey Coles, Javier Crespo, Sharon Hahn, Derek Johnson, Brian Leaf, Sarah Levenletterer, Carolyn Martin, Nisha Moody, and Tony Nigan. In the span of 4 months, this team devoted significant time and effort to offer this fantastic virtual symposium. Thank you for developing the program. As you know, the symposium has continuing education credit from the Medical Library Association and from the National Commission for Health Education Credentialing. You will receive an email evaluating today's presentations. Upon completion of the evaluation, you will receive instructions on claiming your continuing education credit. We are aware that if you completed the evaluation yesterday and tried to claim MLA-CE, the code did not work. Upon completion of today's evaluation, the CE code should work to allow you to claim credit for both days. CE codes will only be available for 30 days following the symposium. Thank you for attending the NNLM COVID-19 Infodemic Symposium. We hope you gain valuable information that can be used to support COVID-19 and vaccine education with the communities you support. If you missed the keynote or panel presentations, recordings will be available on nnlm.vfairs.com for approximately 30 days. Following that period, the NNLM will make these recordings available on our YouTube channel, so feel free to subscribe, and you will be updated when the recordings are added. And again, finally, thank you all very much for attending. Thank you for a wonderful event, and I hope you have a wonderful weekend and can input and influence and use some of the information that you've learned during this event. So thank you very much.